Thank you, Madam Chairperson, for the kind introduction. Assalamualaikum and very good morning to everyone. Okay, so we proceed with the next topic on basic principles of eyelid surgery. So for today, we will cover on anatomy of eyelid. This is the basic thing, okay, the most important topic that you all should know. And then the main goals in traumatic eyelid repair, the general principle in traumatic eyelid repair, the principle of wound closure and the sutures, techniques of eyelid repair, post-op care, and also the complication and management of eyelid repair. This is the anatomy of the upper eyelid. Okay. This is the most important and famous question in the exam, right? Upper, and don't forget the lower eyelid anatomy. This is the upper eyelid anatomy. Okay, the outermost actually is the skin. Okay, followed by the subcutaneous tissue, the orbicularis muscle. Okay, this is the septum. The septum. Actually, this septum divide the upper lid into anterior and also posterior lamella. Okay, so is the orbital fat behind the septum, and then this is levator aponeurosis with the tarsal plate. Okay, the tarsal plate, and then this is the conjunctiva, palpebral conjunctiva. Okay. This is the anatomy of the lower eyelid. There's some differences in between upper and also the lower eyelid anatomy. Okay, you must know how to draw actually. Okay, for the lower eyelid anatomy, the outermost actually is the skin. Okay, the subcutaneous tissue, and then the orbicularis muscle, followed by the septum. And this is the orbital fat. This is the tarsus. This is the inferior tarsal muscle, the purple color. And then this is the capsulopalpebral fascia. So the outermost is the capsulopalpebral fascia, the inferior tarsal muscle, and also the conjunctiva. And then this is the conjunctiva foli. Okay. And then continuous with the capsulopalpebral head. This is the inferior oblique muscle. Okay, this is the capsulopalpebral fascia, and then followed by the inferior oblique muscle, and then this is the capsulopalpebral head, and then inferior rectus muscle. Okay, you must know, you must remember. Okay, these two anatomy, you know how to draw and label it, because this is very important before you proceed with any eyelid surgery. Okay, the most important thing, for example, in eyelid laceration involving the lid margin, you must identify the grey line. Where is the grey line? Okay, this is from outermost and innermost. This is the rows of eyelashes. Okay, so the grey line actually is located in between the row of eyelashes and also the meibomian gland orifices. So this is the grey line. So this is the first thing you need to identify, or first structure you need to identify. You must anchor this one first before you proceed with DNS. Otherwise, it becomes like, the anatomy is already out. It becomes entropion or entropion like that. So you must identify this one first, then we proceed with others suturing. Okay. So the main goals in traumatic eyelid repair actually well-planned approach to achieve anatomical alignment. This is very important, anatomical alignment. We don't want to create the complication of post-repair, for example, entropion, okay? And then maximize the result of primary repair. Minimize the need for secondary reconstruction. So we as a general ophthalmologist, we should know how to do the primary repair. Okay, because we don't want to prevent the complication. We don't want to have complication later on that might need secondary reconstruction. Usually, this is why we need to refer to our colleague, oculoplastic team. And then avoid lip margin notch and also secondary trichiasis. This is one of the complications that might happen. And then we need to restore the structural integrity of the tarsus, limit cutaneous and deep scar, and avoid leg of thummus. These are the main goals in traumatic eyelid repair. The general principle of traumatic eyelid repair, okay, the first of all actually the pre-op evaluation. So if patient comes to you when you're on call, you must ask patient if patient fully conscious, okay, you must ask patient about the detailed history, how this happened, including the time, the cause, because it's very important for the medical legal purpose, okay, and then the mode of injury, and then associated injury, and other life-threatening, for example, ICB, okay, intracranial bleeding, or lung injury, okay, cardiac contusion. So this patient need to stabilize first by the respective team. Usually we get referral from BD team, right? Okay, so make sure that this patient stabilize first. And then for our side, actually detailed ocular examination is very important, including the vision if patient is alert and conscious, CCS fluid, and then we check for the pupillary erection. EOM and IOP actually we need to differ first because we need to rule out the laceration, okay, I mean the globe laceration. Because the globe injury is very highly suspicious in full thickness eyelid laceration. If you receive a referral, they refer to you for upper lid laceration, and that is cut the tarsus, okay, it's like full thickness. So you can see the globe in between the lesion, in between the laceration. You must rule out the globe injury first, globe rupture. So we don't just like do EM, IOP straight away. We must rule out this thing first, okay. And then later, if you suspect this patient had some globe injury, we need to do skull or vital X-ray. Okay, this scan after we rule out the globe rupture. And then CT scan to rule out the orbital wall or intraocular foreign body. So the second one actually the wound inspection, cleaning and documentation. Okay, we need to try to save all the eyelid tissue, which is highly vascularized, okay, to allow for viable reapproximation of partially advanced ocular adjacent tissue. So corpus irrigation, and then we need to explore wound removal for any foreign body. Corpus irrigation also we need to do once we rule out the globe injury, okay. If we can see the orbital fat, so this actually give clue to us, actually there's a risk of deeper injury, okay. And then the precise documentation of the injury and repair also including the photograph. But then the photography actually we need to get consent from patient for medical legal reason. And then the prophylactic systemic antibiotic, especially in severely contaminated wound. Usually we give broad spectrum antibiotic, right? For example, fluoxetine, intravenous. And then make sure this patient had tetanus injection, prophylaxis, IFABT. This one usually given by the primary team, the ED team, before they refer to us. And the third one, we must look for the tear outflow system. Usually we always suspect canalicular injury or in eyelid laceration involving the medial part of the eyelid region, okay. So medial to the punctum, we should suspect, oh, this is canalicular injury because the approach is different from the straightforward simple laceration wound of the eyelid. So if let's say we suspect there's a eyelid laceration, after rule out the globe rupture, okay, we should probe the canaliculi to assess the integrity. For example, if the eyelid laceration involving the canaliculi at the lower part, so we should probe from the superior part, okay, to see. Then we can see whether this is the canaliculi involved or not for the lower laceration. And then this one should be repaired with elastic stenting to maintain the higher patency rate. Usually we use the medium Molokar, the simple one lah. And then if let's say the difficulty in canalicular repair actually to find the distal end, sorry, the proximal end of the canaliculi. because sometimes we need to use inject the air. Okay, once we try to probe from the superior part, okay, superior canalicular to punctum, and then we can inject the air or the fluorescent or the BSS. Okay, sometimes you can use the viscoelastic also to find out. This is the most difficult part lah if severely injured. And then timing of repair in traumatic eyelid. Repair actually you need to reconstruct as soon as possible. Okay, and then management of life-threatening injury takes precedence. Primary repair can be done even after 24 to 40 hours generally, for 24 to 40 hours for the eyelid and also for the canaliculi. For let's say this patient not stabilized yet, so we need to stabilize the patient first by the primary team, and then we can do it later. And then the canaliculi sometimes we can delay for 72 hours lah. And then the excellent blood supply in the eyelid region allows tissue to survive. The fifth one, actually the anesthesia, also very important. For complex laceration of the eyelid, the general anesthesia is preferred. Okay, and also involving the canaliculi, because we need to manipulate, and then we read that the local anesthesia is not enough for patient with underlying bone fracture or in young patient which is not so cooperative. For local anesthesia, with at least 1 in 100,000 epinephrine to reduce the risk of bleeding, and then care should be taken not to inject vascularity compromised flat. This is the anesthesia that is used in the eyelid repair. The local anesthesia can use lidocaine 2%, marcaine 0.5% plus adrenaline 1 in 100,000, total 5 mils, and then premix marcaine 0.5%, adrenaline 1 in 200,000. This is the choice of anesthesia that can be used. Okay, as mentioned earlier, the principle of eyelid repair, we should clean the wound first at initial repair. After, rule out the blood rupture. And then all the wound are examined carefully. Any visible damage is repaired. And the reconstruction must be done in layers. For example, there's a deeper laceration. We don't just like, okay lah, shortcut, just one layer on this. Okay, can cause depressed fracture, depressed scar later on. So we need to close the wound in layers. Okay, follow the correct anatomical orientation. That's why the anatomy of the eyelid is very, very important. We should not extend the wound to explore the structure unless for suspected foreign body. And if it is present or foreign body, we need to remove it as many as we can. Okay. If damage to orbital septum, so should not be sutured. And then should preserve the tissue as much as possible to allow the vascularization for tissue survival as choreographed. Don't remove the tissue like unnecessarily. Okay. We try to save all the tissue. Do not add tissue at the time of primary repair unless cornea is at risk. Okay, this is the flat lah. Usually this one is secondary reconstruction. We try to close during primary repair as much as we can. If let's say it's very messy, we can co-manage with plastic film or oculoplastic. Okay. And then this one actually need to wait for at least 3, 6 or 9 months before repairing the defect. Because we need, for example, lid retraction scar, ptosis unless corneal exposure. So this one need to do early. Okay. This is the secondary reconstruction lah. Usually if let's say the injury very bad, so we need to do secondary reconstruction after primary surgery at 3, 6 or 9 months post primary repair. This is the principle of wound closure. For superficial wound, actually wounds no deeper than the dermis and superficial subcutaneous. So it's not involve the dermis lah. Okay, dermis but then not beyond that. And then may be closed with skin sutures alone. The deeper wound, the subcutaneous absorbable suture must first be done to avoid a sunken scar. This is very important. This is very common complication of post repair in eyelid trauma. Okay. So for skin closure, we use the interrupted or continuous suture. But usually in traumatic eyelid, we use interrupted in case of infection later on. So you no need to remove all the suture. You can remove the accordingly lah, the suture that involved in the infection. So interrupted is preferable compared to continuous. And then we can use non-absorbable or absorbable sutures. Skin wound should be closed with slight eversion of the skin edge to avoid an inverted wound scar. This is the example of the suture that we use. 6O Vicryl, 5O Prolene, 7O Vicryl, okay? So usually for the deeper layer, we use the absorbable suture such as Vicryl, 5, 6 or 7. Usually 5 or 6, 5O or 6O. Okay, for kids, we don't want to do STO. Okay, post repair, we can use Vicryl. But there's a risk of suture granuloma also lah. 7O usually for the skin. Okay. Okay, this is commonly used suture, nylon 6O, for example, ethylon, defilon, Brinol. It's a monofilament, not absorbable. This one mentioned already by Dr. Alisa just now. So to go fast with this. And then the absorbable suture, for example, polyglactin 470, such as white or Novosid. Okay, so you must know the. Okay, so the technique of lid repair depends on the type of eyelid injury. So we know that the anterior lamellar and also posterior lamellar actually divided by the orbital septum, right? So if let's say it's anterior to the orbital septum, so this is anterior lamellar defect. Okay, for the anterior lamellar defect not involving the lid margin, we can do direct closure, 3 points suture. I go one by one after this, okay? Microcutaneous flap and also free skin graft. And then we will talk about eyelid margin involvement. And then this one with tissue loss, okay? The eyelid injury with tissue loss depends on the size. And then also the canalicular involvement. These 4 things that I will highlight during this presentation. Okay, this is the anterior lamellar defect not involving the lid margin. So this is straightforward. Okay, we try to close. Looks like there's a lot of tissue loss like from the first picture. But actually, it can be closed with direct closure. This is the post repair, okay? We try to save as much as tissue as we can. This one is not involving the lid margin. So if you have referral eyelid injury, you must rule out the involvement of the lid margin because the repair is different, okay, compared to lid repair only. I mean the eyelid trauma only. And then for sure must rule out the root rupture. This one quite massive actually. Okay, so direct closure. Usually upper lid is actually quite easy lah because we have the redundant skin, okay, at the area. So we must close without tension. And then usually the skin actually can mobilize. That's how we can do direct closure. And then we need to avoid the unnecessary excision. This is the second technique of the anterior lamellar defect not involving the lid margin, 3-point suture. If we get referral like this, the case like this, the trauma is like a flat. Okay, we can use this technique, 3-point suture. Come from this one, okay, underneath this one, okay, come back here. And we can just make a knot here. Okay, like this. So the post-op is like this, then we can close the other area like this. So the knot will be here. The knot will be here. So there's no like skin retraction. Okay? Or like a sunken scar. Quite nice, this technique. You can practice it. Okay, the third one is a myocutaneous flap. Okay, the myocutaneous flap actually we perform in the anterior lamellar defect, not involving the lid margin also, but it's the lesion, sorry, the defect involving the quite deeper layer up to the muscle, okay? So it's in front of the orbital septum, anterior to it. So we stretch into position over the anterior lamellar defect. We make incision here, okay, and then we can just pull the tissue here with the subcutaneous tissue, and then we can close this area, okay. And then the advantage of this technique, actually the mesh for color and texture is good because it's just nearby the neighbor. Since it's being the its own blood supply, so the barebone of free graft also can be covered. Okay. This is the free skin graft. This one usually done by the oculoplastic tip lah. This one for your knowledge actually. Okay, the free skin graft harvested from a donor site and transferred to field and anterior lamellar defect. Anterior lamellar defect still in front of the orbital septum. So the vascular supply to the free graft must be provided by the recipient site for the graft to survive. So this the vessel supply actually from the graft. And then the FTSG, the full thickness skin graft, employ entire thickness of the epidermis and dermis harvested from donor site. So the upper eyelid is the best choice for the reconstruction of the eyelid defect. For example, in this picture, there's a laceration quite deep at the lower eyelid area. So we take the graft from upper eyelid, okay, a free graft, and then we fill up this area to bring the vascular blood supply also, the vessel supply. So other side for harvesting the full thickness skin graft, we can get it from retroauricular or preauricular skin, supraclavicular, and also the upper inner arm. So also been done by the oculoplastic team. Okay, this is very, very important, eyelid margin repair. Okay, it's like bread and butter in our daily practice, right? So there's a few steps, few techniques that we can use actually. Okay, so the initial margin suture, we can use nylon 6/0, and then we need to find the grey line. That's the most important structure for the eyelid margin repair. This way you can use nylons for just temporary to tighten the area, to tighten this, make sure that one oppose temporary only. But usually we can use like this technique. Okay, this is the suture pass through this one. We can use silks 5/0 or 6/0. Okay, the non-absorbable suture. This is the gray line in between the rows of eyelashes and also the membrane gland orifices. So you can pass through like this, and then like this, come back here, and like this. Okay, so this one we are opposed. This is the tarsal plate. Okay, so we need to close the tarsals first. You can use vicry also. Okay, vicry suture. And then this is the knot lah. After we close the tarsal plate, we can just tighten this lip margin, and then we close the skin. Okay, this is one of the technique that quite easy. Normally we can use like just put a suture silk 5/0 or 6/0 from grey line here to here, and then we just anchor it temporarily, and then we close the tarsals first, and then we tighten this one, and then we keep it longer, right? The suture, so that we can STO later on. We can, it's easy to identify actually the knot later on. Alright. If let's say the tension is excessive, so we might need to do lateral cantolysis to make it oppose. Okay, this is normally what we do. Nowadays we rarely do the temporary suture lah. We just like identify the gray line, and then this part of gray line, we just make a temporary knot, and then we suture the tarsals. Tarsals actually not like through and through, it's like partial at least. We don't want this suture knot can be seen through the palpebral conjunctiva, so we can abrade the cornea. Okay, so we close the tarsals like this, and then we tighten this one, and then we close the skin. This is another technique. We use like 3 lines of suture. The first one actually the grey line, this one, and then one more suture in just in front of it, and then one more suture just behind it. So got 3 knots like this. Okay, so got different technique lah. So the tarsals we suture with vicryl 6/0 because it's inner part. Okay, the deeper part of the eyelid structure. So we use the absorbable suture 6/0. So depends lah how big the tarsal cut. So we can use like 2-3 in total. And then the rest of lip margin suture we can use nylon also, 6O. And then we can close the skin with nylon or white quill 6O. Usually for the best outcome we can use 7O. This is what normally the oculoplastic team use lah, because the scar also is less, okay? It's almost non-visible after the repair. And then it prevent the granuloma also lah, the suture granuloma formation. 7O is the preferred size for the skin actually. Okay, for the eyelid injury with tissue loss, depends on the defect. It can be divided into small defect, which is less than 1/3 of the horizontal length. Horizontal length meaning from the medial canthal to lateral canthal. So less than 1/3 considered as small defect. So we can do direct closure. Okay, and then if let's say very difficult to do direct closure, we can perform lateral canthotomy and cantholysis also. Okay, in case of the horizontal lengthening is provided, actually we need more length of the horizontal. So this one is normally done by the oculoplastic team lah. Okay, up to half of the horizontal length. This time is more less than 1/3. Now up to half considered as moderate defect. We call as tensile semicircular flap. Okay, so actually up to 50% lid defect lah. For example, in trauma or commonly in tumor. Okay, patient have tumor of the upper eyelid or lower eyelid, and then the defect is more than 50%, up to 50%, and then we can use this technique. It can be used for both upper and lower eyelid actually. Okay, this is the example like this. For example, there's some tumor here. This part of the tumor, including the margin, free margin here. Okay, this one. So this is large. We cannot do direct close of the horizontal leg is up to half 50% actually. So we need to make a lateral canthotomy here and also cantholysis. So we can move this thing, including the subcutaneous tissue and also the muscle, and then we can move this tissue up to here to close the defect. So it will be like this. So in this type of case, actually we need to explain to the patient we have two scars. Okay, the first one is here, and then the second one is at the lateral part of the eyelid. If let's say the defect very large, is more than half of the horizontal length, more than 50%, we can use cutter beard bridge technique. Okay, so usually this technique actually done in 2 stages, also by the oculoplastic team for reconstruction of the upper eyelid. This is the example, cutter beard bridge technique. This is the defect. It's larger than just now. Okay, it's more than 50%. So we make like a flat here from the lower eyelid, bring together including the conjunctival fornix. Okay, all layers from here, and then this one is first stage lah. So we close this area. So that we supply, wait the graft actually survive after about 6 to 3 months. Okay, then we can proceed with second stage of surgery. So we cut this area. So this one is like the flat here, survive already, and then this is the original one. Okay, this one also be done in tumor of the upper eyelids. Okay, for the Hugo's tarsal-conjunctival flap technique, actually, it is a partial thickness posterior lamellar flap harvested from upper lid to cover the lower lid defect. The same is the same thing actually. You can remember like this one H, Hugo's is the defect of the inferior, okay, lower eyelid. The same technique as cutter beard just now. Remember C for upper defect, H for lower. Okay, this one can come out in the exam also lah. but you must, it's a good if you know this technique. Also in 2 stages, it's the same thing. Okay. This different side of the repair. You mean the upper or the lower lip. And then the next one will be must study cheek rotation flap. This one for very, very extensive lower eyelid defect. Usually more than 75% of the eyelid. So it's like this. This is the defect of the lower eyelid. Okay, for example, in the post excision of the lower eyelid tumor, is more than 75%. So we make incision here, skin up to the muscle, and then we remove medially to cover the entire part of the defect itself. This is the must study cheek rotation step. So the skull will be like this. Thank you. Okay, sorry for the technical error and stuff. Okay, so okay, gentle traction at the edge of the wound with cotton applicator and under the high magnification will help also. So under microscope. Okay. If it is difficult to identify, there's few techniques. Okay, for example, like in this case, this is upper canalicular. So we can we use the punctum dilator, okay, to just dilate this part, the distal part of the upper canalicular and also the lower part of the canalicular, lower punctum, okay. Okay, and then how we want to identify the proximal end of the canalicular? Okay, we can probe the lower punctum and then we can inject the BSS, the fluid or the air, so we can identify. If we inject the fluid, we can see the fluid flow from this proximal end of the canalicular. But sometimes very, very macerated and also it's like it's more than 24 hours. It become like sticky, this area, so difficult to identify. So we can use the BSS mixed with fluorescent to try to find the proximal part of the canalicular, or we can inject viscoelastic also can. Okay. So this is like it takes time lah to identify it usually. So once we find this proximal part of the canalicular, okay, we can try to probe. We can use either pigtail. We don't have it here actually, but it's very, very easy if you pigtail probing. I'll show you, right? Okay, this is how we identify. Okay, this is the pigtail. It's like a pigtail, okay, probe from the distal part, distal end, it's not like this one, okay. Or we can just, the easier one we can use, we can probe from the lower part of the punctum and then it comes here, and then we can see this one, we can just catch this area and then we probe together. So it become opposed. Usually we use suture. There's a hole at the end there. Okay, the suture, the prolene suture or nylon, to anchor it temporarily. Okay, so we can put the mini monocar stand and just pull it, and then it's quite easy. So this one must repair within 48 hours. Okay, this is how one we anchor the thing. This is the mini monocar. Okay, we need to anchor at the pericanalicular area. Okay, you can use Y-quill 60 or 50. Okay, this one you can just, this is the canalicular tissue, right? The pericanalicular. So you can suture here to here, and then opposite, this is the stem. And then here to here, maybe 2 or 3 areas. This one, the suture 3 areas lah actually. And then we can close. the deeper layer and then the skin. Okay. This is another technique how we anchor the mini monoca. We can anchor at the mini monoca, the stand itself. But I prefer this technique actually. We can use Crawford also to intubate the canalicular. And then this stand we can leave for 3 to 6 months. Okay, usually after 3 months, if okay, then we can just take out. And then Vicryl 8 or 9 but usually about 7, 6, 7 to canalicular. Okay, too small also very difficult to oppose, because this one is sometimes like very difficult to find out the peri-canalicular tissue. Okay, because of the bleeding, everything. Okay. This is the mini monoca. We call as monocanalicular stand. This is the like phantom here. Okay. Cap here we can put at the phantom. This is the Crawford bicanalicular stand. We actually can just like probing from the nostril. Okay. The firstly you need to prevent the first one, the excessive edema or hematoma by head elevation, and then pressure bandage, and also ice pack. Actually, we can use ice pack every 4 hours at the wound area, okay, to reduce the edema or hematoma. The post-op wound massage actually to prevent the contracture and also to soften the scar. This one usually after about few weeks post repair. And then for suture removal for the lid or fascia after 5 to 7 days, and for the lid margin 10 to 14 days. That's why normally we just sure that the lid margin suture we keep it longer so that we can differentiate which one we want to STO first. Okay, we don't want it to confuse with the fascia or lid suture. Okay, this is a few complications and its management. The unsightly scar, we can do massage oil, okay, or the baby oil. And then for sunken or distorted scar, can be avoided by accurate closure of the original wound. So it's not like to prevent this thing. And then slightly invert the wound edge during the closure, just slightly invert like a 10 shape like that. Okay. And then the lid heals with large notch. And then we need to excise or resuture. If developed trichlesis from inaccurate closure, we can do electrolysis or cryotherapy. Okay, the take-home message actually, repair of eyelid injury requires knowledge and meticulous approach. Gentle bending and proper alignment should be done, and the aim should be to achieve best possible functional and cosmetic outcome.